So this woman has had the electrodes implanted. These things hanging is, the battery has not been attached yet. We're going to now take the wire, we're going to give the stimulation, and she's going to describe first what she feels like. And then in the second panel, we're going to turn it on, and you'll see what happens, hear what happens. What I want you to do, though, is also just look at her face. Don't worry if you can't hear it real well, but just look at her face.
And that sensational void, what would you rate that as right now, from 0 to 10, from being the most severe void you can imagine?
I'd say 5. Because in many ways it's, I don't know how to describe it, it's like a nothingness. You know, people talk about the black hole, the black depths of depression, the black hole.
You're still in that hole, do you think?
I feel that way. Like I don't feel, yeah.
You hear the paucity of words, you look at that discomfort on her face. She can't even get the words out to kind of describe what she's experiencing, but it's there. And here's what happens when we turn the stimulation on.
Well, I feel calm and harmony. You know, I'm feeling like I want to smile or laugh or joke around. I'm looking at everybody's expressions on their faces. And,
you feel more in tune with the group?
Yeah, more in tune with the group, looking at everybody's expressions. And
So the funniest thing is we're sitting in a room with 4 exhausted neurosurgery fellows who didn't really know what they were doing there. She was responding to the open mouths of these surgeons who watched this happen in real time. So I always am amused to, it was profound because no one was expecting it, and we all sat there and experienced together. The other thing that I think in retrospect was so profound about that first experience was the fact that she was connected to them. And she went from inside herself to outside herself, which is one of the most painful things about being depressed. So we did more. So with Dr. Lozano and Dr. Kennedy, we added another 14 patients for a total of 20. And we saw this same kind of pattern. About 60% of them had this response that even some had that rapid effect, some didn't, but the group that got well and stayed well. And this was a study published out to a year. Dr. Kennedy went on to follow the patients and at 42 months, maintained that kind of effect with ongoing stimulation. When I moved to Atlanta, new team, new surgeon, new psychiatrist, we did the study again, and we got a similar effect, but not quite as good. And everyone was lamenting, was it difference in patients? Was it different? We had done a 1-month blinded period. But that, by the time we got to 2 years, we actually had an 80% response rate. And these were people that had been in episode 4 to 5 years. They had tried, 15, 16 medications, multiple trials of ECT. The best ones were actually patients who had previously responded to ECT and then had another episode, relapsed, and then couldn't respond. So we thought we were onto something. Enough so that St. Jude Medical, the device company, instituted a multi-center randomized clinical trial to make this commercial. And 15 centers, very ill patients, what we thought were quite comparable. 6-month study, everyone implanted active stimulation versus no stimulation. And actually they stopped the study at the halfway mark after 90 subjects because in fact, active did not beat sham. They were equivalent. And it wasn't that there was that same 60% response rate in everybody. was only a 20% response rate. Very few people got well. But because you have people implanted, you have a rolling enrollment, you continue to give people stimulation, you start to give other supportive psychotherapy because no one is any longer blinded. As you followed all of these subjects over months, they were coming in every 3 months, you started to see an accumulation of response. At 18 months, half of them were better, and that was sustained. We have a contradiction. Other centers started looking at other places in the brain. Everyone that looked at it in an open way, meaning the doctors knew it was on, the patient knew it was on, had these 50% response rates. But when companies went to try to do it in a blinded way, it again didn't go well. So many, it's not a huge number of people that have been implanted, but that there's enough patients implanted that continue to do well that we need to understand what are we actually missing here. And this is where actually the story, I think, becomes extremely interesting. I'm having trouble with because the enthusiasm that there was when we reported the first cases, everyone went wild. And then when it goes a little wrong, you go 3 steps forward, 2 steps back, or even 1 step back, everybody moves on. But we still have to deal with, what did we see to begin? What are we missing? Is it us? Is it them? Did the surgeons does it need to be so precise that the surgeons missed something? Did we pick bad patients? Should we have measured something else? We needed to understand what we did. And we went back to what we did always, is try to understand what's different between the people who do well and the people who don't. No one gets 100% market share in anything. We're trying to figure out how to match people for the treatment that's best for them. And we have people in which this may be a treatment that is at least working for them. And it's really important to ferret this out because the durability of this effect is unlike anything that's reported in people this ill. On the left, the data on the more episodes you have with successive episodes, the likelihood of remaining well a year drops considerably. So to have a group of patients that get well and stay well, not 3 months, 6 months, a year, but extended now over 10 years in subsets of patients, it looks as though 50% of patients will actually be well 50% of the time, and these are people who couldn't respond to anything. And if the battery dies, they lose the effect slowly and it can be recaptured. So there's something about it that's behaving differently that we should understand. And to us, the most important thing as neurologists and as imagers was to understand the where. Because the where is something that we can address. I don't know who the right patients are, but I do know that with the tools we have, we can figure out, is there a variance of where we placed it? In the first pass, it really looked on the MRI that the place we were stimulating, the active contact, was identical between the responders and non-responders. So you'd say, surgeon did their job, put it exactly in the right place. But by using the other kinds of imaging in the second panel on the left, we saw that it wasn't about just turning down the activity in area 25. It was about connecting and ensuring that regions connected to area 25 also changed their activity. And that was the difference. And because we also knew how area 25 was wired, what the white matter connections, the cables, the way in which communication occurred, we now had ways in which we could make those pictures. It's called tractography. And you can see on the right panel, who would have thought that stimulating in one contact separated by 1.5 millimeters away could make a difference? Surgeon didn't, none of us did. But when we actually analyzed the data, you can see in the middle panel on the right and the lower panel one contact, those are the connections that are hit by making a small difference. A lot in common, but the difference must be meaningful. So we started to ask a question, and again, an imaging scientist, a psychiatrist, and an engineer. Can we model what are we hitting in common with everyone that gets well? Let's not deal with people who don't get well. People can be non-responders for all kinds of reasons. Let's focus on what we did correctly in the people that have recovered. And it turned out that there was a common pattern in everyone who got well, identically, that we could then use and even see that the patients that got better over the year, that they had missed the full combination of these connections and then had, by trial and error, gotten into those connections. And we now don't have a point to stimulate. We have a whole network to stimulate. And so we have 4 different roadways in the brain to stimulate. And so then the next question becomes, let's put it to the test. Let's take our blueprint. Let's drive around on one of these tractography maps in that person. Let's find the place in that person's brain that can hit all of these connections all at the same time, and have Dr. Gross, our surgeon, put one of the contacts of our choosing there. And now let's just stimulate their same parameters and see what happens and not make changes. And what we found was that instead of 40% getting better, it was nearly 75% getting better without making any other adjustment to anything else we did. So we're encouraged. But we also saw something else that brought it back to that patient I showed you. The better we got at actually doing the implant, the way in which people got better, the trajectory of the response changed. So the red line almost looks like just a line, a linear change over time. But the green line is where actually we did the tractography guidance. And if you'll notice, everyone starts the same, but here's this big drop that actually stays stable. That is actually after a small amount of exposure to the stimulation in the operating room in the right place. A rest for a month doesn't actually go back to where it started. And when you turn it on again, it goes down again. And this blue line is our latest group. And the only difference about that latest group, we're using a different device, but really stimulating the same way, is we now give repeated stimulation in the operating room, not just on one side, not just short amounts, but about 15 minutes of bilateral stimulation in the correct place. And as you can see, there's a much more dramatic drop. And if the cardiologist that was in the meeting earlier is here, this is cardioversion. I like to see this, that we reset them in the operating room. And then there's a carryover when it's off. And then we stimulate and actually have got something different. But there's 2 phases now to this recovery. So we now need to be thinking out of the box. How do we go from a patient saying, whatever you did, I just shifted? This is really, for the physicists, this is a nonlinear state. This is a bistable state. People are in a local minimum. They can't move. Stimulation is applied, they're popped out. But that second state isn't so stable either. But with continued stimulation, the patients describe that with their own work, which they'd never imagined they had to do, there's the evolution of the recovery. So this is where, using all of our tools, we can start to say, how is the brain changing? What's changing first? What's changing second? We start to see that area 25 changes in the period from the operating room. Once that's affected, it's done. But remodeling the cortex, the thinking brain, the frontal cortex, takes time. And you don't see the effect until you get ongoing stimulation. And this is this bar here. The important thing is the people who didn't get better kind of stopped having changes in their frontal lobe. So we start to have a way to think about, we need ways to track what happens in the brain faster. And this is where the technology is really helping us, because now we have technologies where we can measure the brain signals all the time off the battery because there's a chip and a recorder. And we can start to look at the brain wave activity and see if it can give us a clue to this transition. Or we can bring them to the lab, or maybe we should have them just tell us how they're feeling, or maybe we should monitor how they move. We've suddenly got all kinds of ways that we might think about it. But again, observation, listening to the patients. We've gotten now, how do you rate void? I have no idea. You know, you use every rating scale and realize your rating scales are inadequate. So what we started to do is just let the patient tell us what it feels like. And here are the kind of things people say: gnawing, sticky, quicksand, or paralyzed or disconnected. And what we want to know is which of those things change, and when they're in the operating room, those are the things that they monitor. And what you see, where we thought that to call it a depression switch was wrong, it turns out that depression switch is part of it. And that one patient brought this picture to the operating room. I had no idea what the point of this picture was. To her, she couldn't even put into words what it was to be drowning in that sea. And when we were in the right place, all she said was, "I'm on the rock." And it took some questioning to wonder what rock she was talking about. And she said, "Look at the picture." I don't know what that is. I don't know the computation that explains that, but that is something that happened in real time. And you can see the kinds of things that patients described. They feel lighter, they feel less heavy, they can breathe, the tension is gone, the pain is gone. And when the pain lifts, they feel connected, optimistic, and they want to do regular things. Walk my dog, make some tea, clean up the house, see my friends. And we can start to parse in the most basic neurological ways, what connection were we in that went with these different changes? And we could start to see which part of our blueprint is driving what symptoms. So, sorry. If that helps us to know what to do in the OR, now we need to actually look at what is the hard part of recovery. What's the slow part? Because everyone who's ever taken care of any person with chronic illness knows. You start to get better, and then do you trust it? If you've always relapsed, when is it going to come back? How do you hold back? How do you help someone to actually lean in and use being well? And what we saw in our numbers was that you started to get instability, not early, but after 2-3 months, when your family expects you to start doing something. When you start to realize you've been ill, out of touch, what are you going to do? How do I get a job? Where are my friends? And that different patients have these instabilities in different ways. And the psychiatrists have to determine and start to learn, no, you're just having a bad day, hang in there. We need to get you into therapy, versus, no, I think you are needing an increase in dose. And this is where machine learning, what signal do we use to know? And this is where we are now, and that the new technologies really need to help us. And what we're doing is, with the brain signal, with machine learning, and accepting that we have imperfect readouts, but can we see if our clinical severity readout has got a brain correlate that we can track off the device? And it turns out we can. But we start to see that where it looks as though the machine doesn't match the rating scale is where the machine, the brain, says you're fine. and the rating scale says you're sick. And so we're really starting to reverse what is well and how should we measure it, and how can we start to distinguish what is the illness signal from just the ups and downs of everyday life. I think the future is also not about not talking to patients, but actually using the information that we have that really helps us, and the obvious things. We know all about how muscles of facial expression move. Anybody that sees anybody that is negative, you can tell when someone you care about is in a low mood. But when you're depressed, your face is wrong. You know it's wrong. You don't think your own face reflects how you feel. You don't know what other people are getting from you. And you can see that patient. You don't need a word. You don't need a rating scale to see that that person is different. And what we've started as a shorthand in the lab, we have a joke. They look different. They look different on that operating room, and you can see it in real time. Then the next thing that happens is they do more, even though they're not really aware of it. And then they just do stuff. And it's not till later that they put together their body moving, their intent to do something, that the natural habit of life is just kind of back in gear. So we're trying to figure out with new technologies how to get better pictures, how to steer the current to different parts of our network, how to get different readouts in the brain. Maybe we can analyze the voice, maybe we can analyze the face, maybe we can just watch them move. And that's part of the intent of my new colleagues and my new surgeon, Brian Capel, and new psychiatrist, Martin Fagui. But we're also partnering with our movement disorder colleagues. And we're looking at, again, the imaging, the electrophysiology, the computation, because all of this together is how we'll move the window forward. Now, I'm just going to end, because I started with the patients, and I want to end with the patients. You know, what must it be like, you know, to imagine and live with a machine, and also to have the expectations of what is going to happen when you enter into an operating room. You're entering into an experiment. And as you come out the other side, what patients become very aware as they look back is articulated here. This patient, you know, brought this little painting. And I think this is where we all are. Life is hard. But that it's worth the struggle. That when we work on these kinds of things, we need meaningful relief for patients. We can't delude ourselves that we're doing something and we have a picture of it. It has to be meaningful. But we actually now need to develop the rehabilitation strategies that maximize what the machine is doing. And patients need to be taught new habits. Feeling negative is not necessarily being depressed. And again, this patient recognized how much she had to learn and that she was very lost as she was recovering. And as she was figuring out, the one thing she was very sure of is that life was hard and she was overwhelmed by what she was going to do, but she was definitely no longer sick. I'm going to leave with this other metaphor. I think, you know, the cardiology metaphor, if you can have chronic heart disease, get a arrhythmia, and maybe all the operating room is at cardioversion and you put in a pacemaker, and then you go back to how you're going to exercise and kind of maximize your chronic heart disease. Or maybe it's actually like a broken bone. And I think in a very concrete way, it's more like a broken bone. You know, you don't try to run on a broken bone, and you actually don't try to use yoga or physical therapy on a broken bone. Fix a broken bone. And when you fix a broken bone needs some time to rest, remodel, till you're sure it's solid. And if you start doing something on something that's not quite healed, it hurts and it's a useful sign. But once the bone is healed, you have to rehab, and it doesn't feel so good. You have a trainer, you have a guide. Passively, someone moves your leg until you trust it, but then it's about you. You have to relearn, you have to exercise, it's hard. And then eventually, it's a plastic change. You may be better than you were previously. The last thing is I want you to listen to an interview of one of our patients in Atlanta who was interviewed for a program on BBC called Digital Human. And it was actually a provocative interview about patients as cyborgs. And there are people who like putting chips in themselves to monitor themselves. And I asked this patient who owns and talks about the device to actually go on the show. And I want you to hear it because this is the ethics of this. When people talk about you change people's personality, you make them somebody else, what are you doing? You listen to what Brandy has to say, and then we can discuss it.
When you forget the technology is even there, once that transformation is complete, are you more or are you less human? For Brandy, the answer is clear.
Being a cyborg absolutely restored my humanity. Depression had wiped out my personality, my ability to cope or function, my ability to interact with people. And becoming a cyborg has restored my ability to be a member of society and to have compassion and empathy and to interact with people. So I am now part of the people around me because I have this implant.
And
I am a cyborg for the rest of my life. And I'm okay with that because it gave me a life. But it is something that is part of my identity now.
thank you.
So we will have questions and answers.
Okay.
I request you to take place.
Ladies and gentlemen, I'm sure you would agree with me that was a scintillating performance. Please give her a big hand. May I request Professor Gangadhar to moderate the questions and answers. I'm going to request those who ask questions to introduce themselves and be brief. Thank you.
Yeah. Topic is open for.
I am Professor Venkateshwaran. I teach MBA program students. It was a very scintillating, very splendid presentation. Thank you, madam, for enlightening us. Low self-esteem and high self-pity could be the trigger point for depression. Is it true? And another thing is, can you enlighten us on the brain behavior in a comatose stage when people are by accidents or otherwise go to comatose stage? How is the brain behavior, and could there be any implants that could trigger the status quo ante by helping the patient to come back to the normal stage by implants or by stimulants or any other device to help the comatose patients?
Okay, so we have two questions. The first is the origins of depression, and this could have been a much longer lecture. Depression has many causes or presumed causes, and low self-esteem, or particularly in the setting of early childhood trauma or neglect, is certainly a risk factor. Stressors in life can precipitate that in people who are vulnerable, but in fact that it's not the only reason. And I think the way to look at causes of depression, it's a different approach. That I think that we have patients who had early trauma, We had many patients who actually had very high self-esteem, were very established people. I think that depression doesn't discriminate, but that there can be many routes. And I think that once your brain reaches that state, it actually, you need to put it, heal the bone, and then actually deal with those other factors that now need to be treated as well or assisted. So I think that it's separating the state of the brain when you're at your nadir from actually how you got there. It's like, you treat the heart attack differently than you treat the high blood pressure or diabetes that leads to the heart attack, and I think that's similar. In terms of treating coma, there has been wonderful work from Nico Schiff and others in actually treating minimally conscious patients. So they're not vegetative, they're minimally conscious, but they are certainly not engaged. And targeting particular nuclei in the thalamus has been done, and it's quite remarkable, and the work goes on, and it's the focus of experiments in people that are a little less ill to try to actually see what are the pathways in consciousness centers in the thalamus. So again, that strategy, people are investigating it, but it's really not ready.
I am Dr. Chokkalingam, cardiologist, and really appreciate. I got a few questions. You said 5% of the total population are depressed. My personal feeling is 100% of the population are depressed one stage or other. The whole audience, sometime or other, are depressed.
Not just 5%.
So depression is the one factor of any human being, but how light and how they come out from that is much more important. Another question I would like to ask you, if you're going to get a depression in the Bay of Bengal, it becomes tsunami and kills lakhs of people. If a person goes for acute depression, also it kills them, mainly as a heart attack and kills them. I want to ask you, how many patients percentage they are aware of themselves as a depression? They come out with you that they are depressed, or the parents bring them that their spouses or children are depressed? Are they really aware of themselves they are depressed?
Are they aware if they are depressed?
Okay, so that's an interesting set of questions. I think I just want to make a kind of editorial comment. I think the word depression is a bad word to describe the state of the people that we treat. And I think that in terms of, we heard over the last couple of days the stigma associated with surgery for epilepsy. I think that people presume to know what being depressed is because we use the word as a vernacular word. I know what having a bad day is. I know after seeing and being with these people, I don't know what that feels like. I have never personally experienced it, and it sucks the life out of me. It is a black hole that we all feel when you're around somebody. And when I feel that, that is the patient that I am treating. And that, but on the other hand, and in North America particularly, we treat the walking wounded. People are fragile, people are stressed. The same systems that break down. And I think that is, kind of what you're talking about. And those people need treatment too. They just don't need an electrode. And they should never be anywhere near an electrode. And quite frankly, I'm not sure that it could be very good even if we could do it and we could do it outside your head. I think the interactions of, the heart and the brain and all of these things are interesting for the very reason that the last pathway to be damaged is actually the region that regulates your autonomic responses, both your facial expression and your autonomic system. And that region projects down to the adrenal medulla and also may help to link why heart disease and depression become interactive. In terms of the being aware of being ill, what's fascinating about people this ill is they know they're ill. People around them know they're ill. But as you're ill this long, the habit of being basically the same, you actually on the rating scales don't even look that severe, because compared to last week, last month, last year, you are -10 with no standard deviation. You have no dynamic range. And I think the patients behave as though they are anosognotic. In essence, they have they've lost the capacity to know where they are. So it's not that they don't know that they're depressed. They don't know how down or where they are. They are lost. And you know, the hippocampus is atrophic in more chronically ill patients. And the hippocampus does not just your memory, but your spatial navigation. And so the notion of when patients feel lost may be more than a metaphor, because they really lose their capacity to know where they are relative to other people. And what becomes where they lose their capacity, they cannot remember when they were last well. I mean, what do we do when we're in pain? If you're at the dentist, you kind of think about the beach, or if nothing else, you know it will end soon. What would it feel like if you had no capacity to project your past into the future? And that's what they lose. And that's why when you hit the switch in the right place and someone says, I'm optimistic, it's because the thing they couldn't imagine being able to do comes into focus and they can see how they're going to get there. So I think that's the nuanced thing that they lose. And once they're better, they actually forget where it was that they came from, and that process takes some time. So there's a very interesting way in which you reestablish your neutral position. The brain is changing and you need to kind of get to stable ground so that you can actually repopulate what's a true positive and a true negative for you. And I think that's the part that takes time. I think in some ways, I think just switching, getting the brain to work and then training it is really what we're talking about. And I think that's fundamentally, that's something that we'll need to do the experiments to prove, because that's not a popular notion. But that's how it looks from this side of the patient.
I am Dr. Aramudan, practicing physician.
Come closer to the mic, sir.
While treating a case of depression, many drugs do not act, or they become inefficient within a short time. Then we diagnose it as a refractory depression. When you use novel antidepressant drugs, they become resistant, that too within a short time. When we refer the case to psychiatrists, they treat with the ECT. ECT also fails. Do you think these patients are subject to DBS within a short time so that the effect will be rather felt? At the same time, newer antidepressants can too be tried along with the DBS post-effect. Can you please explain the circumstances?
So I think you're pointing out some of the kind of weaknesses that we have with treatment of depression broadly.
That's correct.
That you know, we're probably treating symptoms. And it reminds me a lot of if you treat an infection and when your symptoms are better and you stop the medication, you may actually have the continued infection brewing, and what you've just done is breed stronger infectious agents. Or in cancer, we're seeing that you can modify the cancer and that things modify. And then you have a more virulent form of the tumor, even though you had done a good job of killing the cells originally. I think that fundamentally, we forget the fact that all the things that we've talked about, because we have so many neurons, there is plasticity. The brain is never the same. If you introduce a medication, it will adapt. And the new state it's in will be vulnerable in a new way. And I think that in some ways we're just looking at accumulating hits. It may be that not that we're not doing a bad job, but that we do a good job, but that fundamentally the brain tries to go back to another state, that itself was a maladaptive state, but it is your state. And I think that that's why we have to rethink more about what plasticity is, what regions we need to modify and why. And then we might understand that, because these depressed people act like multiple sclerosis. They have, some multiple sclerosis patients have a single episode and then they recover. And others develop a malignant change and become chronically progressive, and it's never really quite clear why.
We'll start with the lady.
I'll go faster.
Thank you.
Okay.
I'm Dr. Pavitra, a psychiatry resident. I was just wondering if their environment and other psychosocial factors also play a role in the response. So if we look at a more global approach, can we expect more response from the patients we've been treating?
The short answer is absolutely. And I think that, I can't know what went wrong with the clinical trial. I just know what goes right with my team. And the thing is that the relationship, just like Dr. McCann talked about, and Dr. Ford, in terms of the interaction of a patient team with the patient, that we are all part of their rehabilitative process, as is their family. And if we act as though the machines or the medication alone does it, that we fail. We probably affect a partial change. It just doesn't help the patient much to be an effective person. And so I think it is the interaction that we really need to work on. But I think our important challenge is, what's the timing of what treatment when?
Thank you.
Hello, this is Aparna from Mind Zone, a psychologist. My question is, have you ever tried doing DBS with patients of schizophrenia with negative symptoms? Since you correlated the Parkinson's and depressions, negative symptoms of schizophrenia and depression may correlate with each other. So have you ever tried doing it?
No, but I think you bring up a really, really important question about the lack of precision in shared languages across our discipline. I think we have to separate negative symptoms of schizophrenia from abulia, from apathy, from depression, that they have features, they probably have overlap in symptoms, but the nuance difference. And I think that studying all of these disorders together is going to really help us know what is what. The group in Barcelona has done some pilot work on the ventral capsule and the subclosal cingulate in schizophrenia, but I don't know the results.
Okay, thank you.
My name is Vivek from Neurokrish. So my question is, with the advancement in the RTMS and the other, like we are having now, the deep TMS is also there. So with that, is there any change what you will see in selecting the DBS over the TMS when those coils also are penetrating quite deep?
So first of all, they don't penetrate deep enough. So deep is a little bit deeper in the cortical surface, not to the bottom of the frontal lobe. So they can't do the same thing. But even if they could, I think fundamentally the difference between going at cortex and going deep, in principle, it would make sense. The problem is that if you believe that you can excite the cortex to affect a deep structure, that pathway better be intact. And so I think that the reason that we have many patients that have failed TMS and respond to DBS is that when we start to look at cross-sectional groups of different groups of treatment-resistant patients, the connectivity patterns can be distinguished. So I think that we are watching these successive deteriorations of this network, and we need ways that we can characterize the network and then pick an external stimulation approach versus a deep approach. I think they fundamentally are working. I think in TMS, the system is intact but poorly trained, and that you can change excitability and someone can actually function. But I think the DBS may be having a very different kind of effect.
Sir, before you, I have an elderly man asking a question. Yours will be the last question. Yes, sir. Please go ahead.
I am Dr. Radhakrishnan, retired professor from IIT Madras. I have one question. Are the autistic children generally under depression? If so, can deep brain stimulation be done to them?
Autistic children, are they going to depression?
So I think it's twofold. I think autistic children that are profoundly autistic, I'm not experienced to know what they're experiencing. It's very clear that self-injurious autistic children can be assisted in very specific cases by stimulation, but there has not been systematic study. But there are anecdotes in which it has relieved self-injurious behavior in autistics, but I don't know that that translates.
Oh, thank you.
Last question.
Okay. Please.
Yeah, I'm Dr. Rajagopal, consultant psychiatrist. One of the issues that psychiatrists face when treating patients who are very depressed is the increase in suicidal risk just as the patient starts to improve. So the psychomotor retardation gets better first before the mood improves and before the hopelessness gets better. And that is especially so for treatments like ECT, which work very quickly. So you mentioned that you have noticed changes in the patient's mood just as the procedure is being performed. And these patients have been depressed for many years. So have you noticed any cases where there was a sudden increase in suicidal risk just as they got better? And is there,
No, interesting question. So one, this kind of residual anosognosia, they actually think they're still ill because almost the habit of, like they're out of shape, they're moving more, but the feedback is off. I think when the drama of this release phenomena in the operating room, even if they start to feel bad again when they leave, I think, you wouldn't have an operation unless you thought it might work. But you shouldn't have expectation it would work if you're at the beginning of a study because nobody knows if it's going to work. But whatever that experience is, the patients say that it gives them hope that they didn't have, because most of them don't actually think anything can work, even if they're willing to give it a try. But you're asking something a little more nuanced. They all have the sense that they'd be better off dead, but we are very careful because it's not an approved treatment not to enroll people that have active suicidality. It's not like ketamine where actually you can break the active suicidal thought. We have not, in the clinical trial, there were 2 suicides, and they were in placebo patients after they knew they were in the active phase. So that there is another layer that doesn't seem to be related to the physical suffering. We had one patient early who had a kind of existential, always had a couple of points on the Hamilton, and he was well. It was the only points on his Hamilton, and we had him speak with our head of the Psychoanalytic Institute because he actually had an existential thought about suicide. But after a couple of years, that too, as he really kind of incorporated a new life, that was gone too. But this rapid, kind of agitated and you're moving, I think that we're not seeing that, and I haven't seen that described.
Madam, this is the last question.
Yeah,
Sir,
Dr.
I think we have to stop at 6 o'clock. We have to close the...
Dr. George.
Madam, one second, sir.
I'm Anne Gonzalez. I work with an NGO dealing with patients of multiple sclerosis. Today, there's a lot of talk about depression being linked to poor gut bacteria. Would you be able to explain whether DBS could help such patients?
Oh, so that's an interesting question. I mean, the microbiome is fascinating. And the story of the microbiome and also inflammation in depression is a hot topic. And there certainly is evidence that there are a group of patients that have high inflammation, and that may be a mediator of stress responses. And that the areas of the brain that are mediating kind of the combination of stress, glucocorticoid, and even these inflammatory responses kind of intersect this circuit in some ways. That said, we actually don't see high inflammation in these patients. We haven't looked at the microbiome. But we heard earlier about vagus nerve stimulation, and actually instead of thinking about it as going up into the head, to actually be using the vagus to go down to the body. And that it's being tested for rheumatoid arthritis. And the issue is inflammation pointed to the periphery. And you really wonder whether or not that strategy in people who have actually got these hyperinflammatory states. So it's not a direct, comment on the microbiome, but I think that some of these peripheral stim approaches are starting to get very creative, and that's probably a place they ought to look. You ought to look at the vagus nerve stimulation studies for rheumatoid arthritis, because that might be an interesting overlap.
Thank you, Professor Mayberg, for taking all those questions. I'm sure that we all have many more questions, but we'll have time to talk about things over tea, and several international faculty you can approach to ask for responses. I have the great pleasure of saying thank you, but before that, just the take-home messages. I think we've all understood the impact of depression on a person. It's an invisible disability. When I'm physically ill, it's easy for other people to understand that I'm ill. When I'm emotionally unwell, it's very hard for other people to understand that I'm emotionally unwell, and we need to keep that in mind. I think Professor Mayberg has brought it beautifully to us. It's no different from breaking a bone. It's a disorder of the brain, and we need to understand it and treat it as a disorder of the brain. And I think while new technologies are making us think so differently about how we will approach these conditions, and I think we are limited, like Paramahamsa Yogananda said, we are all victims of our experience. We are limited by our experience, and we need to open our minds and embrace these new technologies is the third take-home message. And the final take-home message that I think we all need to keep in mind is that it's not just about putting electrodes in people's heads. It's about care, it's about rehabilitation, it's about the family. And in India, our biggest asset is the family, which is the fountainhead of all care for most people. So leave you with those few take-home messages. It's a great pleasure to thank Professor Mayberg for a wonderful lecture. Please give her a big hand once again. I'd like to thank our visiting professors for being with us over the last 3 days and for sharing their knowledge and doing so well. Professor Ford, Professor McCann, Professor Ashwini Sharan, a very big thank you. Professor Pedley, a very big thank you to you for making all this possible. I'd like to say a very big thanks to Mr. Venu Srinivasan and members of the T.S. Srinivasan family. Please give them a very big hand. We are entering the 40th year, and I think 4 decades of a program does make it more than an institution. It's longer than many institutions last. I'd like to thank the NIMHANS team, Professor Gangadhar, the director, and Professor Matthew Varghese, who helped us put the program together, and everyone else at NIMHANS. I'd like to thank my own team, the NeuroKrish team, for working so hard. I'd like to thank members of the press for being here. It's very important that this message about this important condition, which is one of the most disabling conditions in the world, and the prospect of new treatments for it does get out there and people get to understand it. So thank you for being here. I'd like to thank the many people involved in organizing this program, from the TVS team, Mr. Lakshmanan and his team, as well as Bala, who worked so hard with us to put these programs together. And last but not least, I'd like to thank all of you for taking time off on a Sunday, for being here. Thank you so much. Thank you. Please do join us for high tea.